Sedation is a cornerstone of ICU care for mechanically ventilated patients. But what happens when the world runs low on sedatives, like during the COVID-19 pandemic? The ProActive trial: Can propranolol reduce sedative needs in ICU patients? In the thick of the pandemic, ICUs faced a critical shortage of intravenous sedatives like propofol and midazolam. With drug supplies stretched thin, the need for sedative-sparing strategies became urgent. Propranolol, a non-selective beta blocker, caught attention. It's cheap, available, crosses the blood-brain barrier, and has been used off-label to treat anxiety, PTSD, and even agitation in brain injury patients. So could propranolol help reduce the need for traditional sedatives in the ICU? The ProActive study was a multi-center, open-label, randomized controlled trial conducted across 3 academic hospitals in Ontario, Canada. Researchers enrolled 72 critically ill adults who were mechanically ventilated and receiving high-dose sedatives like propofol or midazolam. Patients were randomized into 2 groups. The intervention group received enteral propranolol, starting at 20 milligrams every 6 hours and titrated up to 60 milligrams based on sedation needs and hemodynamic stability. The control group continued standard care with protocol-driven sedation only. The primary outcome was clear: how much the sedative dose changed from baseline to day 3. Secondary outcomes included sedation quality using the Richmond Agitation Sedation Scale, also known as RASS, the use of other sedatives or opioids, adverse events like hypotension and bradycardia, ICU and hospital length of stay, delirium, and mortality. And here's what they found. The propranolol group had a significantly greater reduction in sedative use, 54% versus 34% in the control group, with a p-value of 0.048. RASS scores within target range were better in the propranolol group, 48% versus 35%, with a p-value less than 0.0001. No significant increase in adverse events, ICU stay, delirium, or mortality. Interestingly, fewer patients in the propranolol group needed new benzodiazepines during the study. Tracheostomy rates were also lower, though not statistically significant. This trial highlights that propranolol, a drug most clinicians already know well, can safely reduce the need for high-dose sedatives in critically ill, ventilated patients. This could be a game-changer in times of drug shortages, in resource-limited settings, or when you need to avoid deep sedation complications. However, this study wasn't blinded, and the sample size was modest. It wasn't powered to detect changes in long-term outcomes like mortality or PTSD, though trends were favorable. So, should propranolol become a routine sedative adjunct in the ICU? Not yet, but it's promising. The results support further large-scale blinded trials to explore not just sedative reduction, but also patient-centered outcomes. And until then, in a crisis or shortage, propranolol may be a safe, effective, and affordable tool in our ICU arsenal. This was the ProActive trial, another example of creative thinking in critical care when resources are strained.